Now we have SAVARI DESAI, who will be talking about the subtle signs in surface tumors.
Okay. Thank you, Swati, for inviting me for this talk. And it's good to have people in the audience. And hopefully, in the end, we can all learn from each other. I think Prerna covered a few of the top, not all, but just started off the whole sentiment of how we can pick up certain things. So, why like subtle signs, and what is the purpose of subtle signs? So, the whole reason for picking up these signs is to diagnose it a little earlier so that we may be able to pick up pre-malignant lesions, to prevent deeper and wider spread, which requires more destructive surgery maybe, and to try and have a more conservative approach so as to be able to not have to go to that level. Also, I think that subtle signs are important because instead of just labeling one thing as just, oh, it could be a pterygium or something like that, it allows you to think and say, okay, it could be something else before the patient moves around to 10 places and comes back with a stage where it's sort of beyond repair. So, ocular surface tumors are just broadly classified into epithelial, stromal, caruncular, metastatic, secondary, which are further classified into non-melanocytic and melanocytic. So, the way we teach the residents is that just like we document corneal cases, we document our conjunctival tumors and eyelid tumors, in which even she showed some, very good tumors where location is important in terms of the interpalpable surface being one of the most common areas because it's exposed to various type of lesions, also the limbus. But also we need to look at the fornix and the tarsus, and those are sometimes have lesions which really give off the subtle signs and give us a clue when I'll show you some cases. Then mobility or fixity to the underlying structures, consistency in terms of whether it is park-like, thick, cystic, thickness, color, which gives a very good giveaway, and also the type of vasculature we see. So the simplest thing we can start with is these lesions which are commonly seen, especially in our population or our race, which are these small whitish looking frothy lesions, often on the nasal and temporal aspect, maybe a little triangular, but not really whitish. They have a subtle pale sort of yellowish appearance. And if you look, they don't have anything what we call as feeder vessels, no vessels inside the lesion known as intrinsic vessels. Just they're sitting there, and basically some of them usually can be mobile, or some may have little episcleral fixity and are often bilateral, not just nasal and temporal, both eyes. So this is nothing but actinic keratosis. However, the important thing to take away from here is that actinic keratosis can lead to something. So you need to draw it and mark the vertical and horizontal length. So we encourage all residents to mark exactly, besides just taking photographs, so that you can immediately look at it and evaluate it. Coming to this lesion, a little away from the limbus, pedunculated, red, angry looking tortuous vessels, but not what you would call a dilated or a feeder vessel. It's just vessels all around it. So this is a very common condition we see. That's pyogenic granuloma. Pyogenic granuloma actually don't have any preference for location, and that's also one of the subtle signs that you will find may be associated with some history of subtle trauma or an insect, and will have a short and rapid history. Coming to another bilateral lesion is seen in this patient. He was a farmer and had lesions in both which he felt had grown. But actually, if you go to see and you see close, there are again no feeder vessels. But what it had is a very fibrovascular frond which was encroaching on the cornea with a little bit of patchy appearance. So this is actually nothing but pterygiums in different stages that we are seeing. One is partially atrophic, one is a progressive pterygium. So often, if they have a doubt, we do send these across to each other. Cornea sends it to us, or we send it, and we just rule out. And it's always better to be, sure that it is a pterygium than to err on the side and say that, oh, okay, like it's not a tumor, and, just go ahead and ignore it. So now this is a very interesting 40-year-old gentleman who had been following up with me for this lesion, and it was much smaller. So it was a well-defined lesion. Then over the last 2 years, he started having a few of these prominent vessels, and one here, as you can see, but still a little bit of encroachment on the cornea. But there was nothing else, which we'll come to, that suggested that I needed to do anything about it, till he came literally in Jan this year with this change, showing some more prominent feeder vessels and a slightish whitish change. This was a change to basically keratin. So this was a lesion which we had diagnosed as actinic keratosis, and specifically it showed that it had changed. There was furthermore enroachment with these little tongue-shaped lesions going into the cornea. There was episcleral fixity now. So this is something we had been documenting by drawing and on photographs. So since we picked it up early, we did not do a biopsy, but put him on topical interferon, and he's actually already done 2 cycles, and it has regressed, and there is no more keratin. So this was an OSSN. Now this was another person who came to us, was referred by my nephrologist, and said that he's been complaining of these whitish lesions. So, and you can see it's just a sort of linear lesion which is there with not really dilated vessels, but then you look up close, and when I stained him, he had these fine punctate stains on rose Bengal. So that even alarmed me, because it was looking suspicious till we stained him on the other side, and we got fine and like proper punctate staining on the lesion. So he was a renal transplant patient. So one of the other things is, if you see multifocal lesions, which is more than in one area, and they are immunocompromised or are transplant patients or on immunosuppressives, this is something that should be immediately you should consider. And we often get these because we have a transplant department in our hospital. So they now know that if there's any lesion on the eye, it has to come to the ophthalmic department for review. So we actually didn't put him on topical. He wanted surgery, and we actually did an excision and followed the protocol for surgery. So OSSN, as we know, these are very frank OSSNs, which are leukoplakic, gelatinous, papilliform, and I've taken some of these are mine, and some are taken from LVP from Dr. Hunavar. And there is actually not much to be said about this. The ones which have exuberant keratin it's like a brainless thing that you mostly know it's an OSSN, and there are various managements for OSSN, which we will not be going into, but these are just the different forms, which are not really subtle, but these are things that, this is the various ways they present. Now coming to a lesion like this, which could either be on the bulbar conjunctiva, and we talked about location. So this is not the same patient, but there was one on the eyelid, and he came saying that it had, one was a young adult and one was an adult. Same kid had a recent history, but they're not that, they don't grow like within a few days, but they have this kind of, flower or like papilliform sort of appearance, all bunching together, and they may have a few feeder vessels. So these are basically papillomas or squamous papillomas, and often they can even be near the limbus, but they have such a characteristic appearance that you cannot miss it. So just to say that feeder vessels are not diagnostic. Feeder vessels can occur in even 30 to 35% of non-malignant lesions. So coming to this is a patient who had been going around for unilateral blepharoconjunctivitis with diffuse redness and was not resolving. And finally, like Prerna said, this basically did a small map biopsy. This is a map biopsy which I had done, and it turned out to be a diffuse squamous cell carcinoma. So this is something that you must think about, especially when the patient consistently keeps complaining that no matter how much topical treatment you're given, there's no improvement. So coming to cornea, these often present as, corneas are very rare, less than 1% OSSNs, but they'll present as a scar, but they have a typical fimbriated appearance, and in Roche, this is a scar while this is an OSSN, and they're elevated. Sorry, I'm running a little short, so I'm going to quickly rush. So coming to the pigmented lesions, this is, slate gate pigmentation. Most of you all know it's oculodermal melanocytosis. The only thing that you need to know is that they have a risk of uveal melanoma. So that is something you also need to look at the hairline also to see if there's any pigmentation, which you need to rule out any CNS melanoma. And types of melanosis. So the one on this, which is bilateral and diffuse and patchy and doesn't have any significant pattern, is complexion associated melanosis, which is the current term, but you can call it racial melanosis, and of course primary acquired melanosis. Now primary acquired melanosis can be with and without atypia, and the ones with atypia, which is a histopathological diagnosis, is the one that can have a chance of turning to melanoma. So the subtle sign here is that if you see a pigmentation which is in the fornix, which is plaque-like and thickened, you can, if it's less than say maybe 3 clock hours or 10 millimeters, then you may want to observe it. If you're still not sure, then you may want to excise it. This is another nevus, but I'm just going to go to the next one. So this is a mixed appearance. It's a conjunctal nevus, but the reason I put this photo here is because it has cysts, it has intrinsic vessels and subtle feeder vessels. So there can be a overlap of certain subtle signs where you may think that it could be either a pre-malignant or a malignant lesions. However, this was a conjunctival nevus and was excised just for cosmetic reasons. But these are some of the subtle signs then you need to look into. I'll just ignore this. And the last one is a salmon patch sort of appearance, which is basically a lymphoma. And you want to see that you don't mix it for episcleritis. This is basically malt lymphomas, which can be treated and have excellent prognosis. So basically, look for the subtle signs and document what you see, chronologically, because a lot of times when you go back, you find there are changes. When in doubt, and review, and always follow up with your pathology. Thank you. Sorry, I took 1 minute.
Thank you, Savari. I'm sure most of us now understand what are the subtle signs that we have to look for in conjunctival lesions. Thank you.